Hi, my name is Jeannie Heck, and this is part two of the interview of myself. I want to bring up a couple of things that I did not mention in part one of the interview regarding getting a position in the outpatient environment versus the inpatient environment. Lately, what we're beginning to see more and more in private practice is that hospitals are acquiring physician groups and physician practices. You're seeing, I'm sure, even when you go to your own primary care physician, or if you've been to a cardiology group or a gastroenterologist group or an ENT, that often you'll see a sign outside of their office that it may be owned by one of our local hospitals in the Philadelphia, New Jersey area, such as CHOP or Penn or Cooper or Our Lady of Lourdes. So the only reason I'm bringing this up to you is that when you apply for a position, and typically the big hospitals have websites where you can go on into their HR or human resources department and you can submit an application online. And if you look at the various positions that are available, in addition to there being maybe positions within the hospital, there may be positions in their outpatient practices. So again, please know that an outpatient position is just as desirable as an inpatient. And as it turns out, you may be working for a hospital as well, because that seems to be the trend that we're seeing more and more as healthcare evolves with the EMR, etc. So what I wanted to do, because very many of you, from what I understand, have not really had the privilege of working in the healthcare environment, what I'd like to do is bring you inside of the office of our physician group and looking at the software that we use. There's obviously more than one practice software, practice management software, as we call it in the medical profession. The one that our office uses is called Practice Manager, and it's by Chartmaker Medical Suite, and they are located all throughout the United States. Again, this is just one version, but what I wanted to show you is what it would be like, what a computer would be like in a private practice or in an outpatient environment, so that you can see how we would enter information into the computer. So you can see up here in my tabs, we have our patient tab, charge, payment, inquire, insurance billing, patient billing, clinical appointment, remittance documents, reports, and labels. So underneath every single one of these tabs is our other options that we can enter information. So for instance, our first one is the patient tab, and if I wanted to add a new patient, I would simply type an A for add in the account number, and then I would start to enter our information. But what I would like to do first is I'm going to show you some real live progress notes. These are handwritten, they are not electronic. Yes, a lot of practices are going electronic. Sometimes the handwritten notes are scanned in, especially in a hospital if they're not completely electronic. As far as being able to understand a physician's handwriting, this is obviously a huge plus for the future of this profession and any HIM position within a department or in a hospital or outpatient. So again, this is what our practice management system computer software looks like. I would say that over 99% of all of our insurance claims are filed electronically, which is terrific. It means it goes right from our computer to the insurer or a clearinghouse computer. And the obvious benefit to this is the turnaround time for payment is very, very quick. With the Blue Cross and Blue Shield, like Horizon, which is the Blue Cross and Blue Shield of New Jersey, we are often paid in less than 2 weeks, less than 14 days. Typically, it could be even as quick as 10 days. The same thing for Medicare. CMS is handled by Novitas in the area of Pennsylvania and New Jersey, and our Medicare claims are turned around in 10 days, which is terrific. So let me show you now some progress notes. I obviously changed the patient name for privacy purposes and HIPAA, but what I did was, this is the face sheet of a new patient, Joseph W. Brown, his age, date of birth, and I highlighted some things that would be important for you to look at if you were a medical coder. The first thing is this patient is on lisinopril, 20 milligrams once a day. Now, this is a really, really great example of how important it is for you to know pharmacology in the medical coding profession. You would need to know absolutely, positively, for sure that lisinopril is a medicine for hypertension. So then you would know that you would be scanning that chart to see if that hypertension is indeed documented, or hypertensive vascular disease, as the doctor here did indicate past medical history of COPD and HVD, which is hypertensive vascular disease and chronic obstructive pulmonary disease. Past surgical history includes a gallbladder and an appendix. Over here on the right side, I highlighted they do smoke. I know when I worked in a hospital, they wanted to pick up smoking on every single patient. And in a doctor's office, it is really the same way. To be all honest about it, the primary reason that everybody wants you to pick up tobacco or smoking is because it does have such a profound effect on a lot of disease processes. This patient is allergic to penicillin, and here the family history, no cancer, but the father had an MI or heart attack at age 68, no asthma. The mother and the father both have high blood pressure, no diabetes. So now let's go down. Here is a preventive medicine section, but let's go look at the actual progress note. So the date, we're making up a date here, and what you're seeing and highlighting is just something that I highlighted in terms of this particular interview, just to make it easier for you. So if you remember, if you had me for the ambulatory coding class, I had told you that E&M coding really isn't that difficult once you're in the real world, because the progress notes that physicians use have a lot of what we call templates. And as you can see, all these boxes to the right, review of systems, review medicine, cancer screening, all of this would enter into our 3 key components, so it's really, really not difficult. This particular doctor indicates that yes, it is an initial office visit, so that means we can code this patient as a new patient, and they write in the SOAP format, which I'm sure that you're familiar with at this point in the program, subjective, objective, assessment, and plan, and I did highlight that so that you can see that what you learned in the textbook really is truly applied in the real world. So let's go through the subjective part of Mr. Brown. Complains of cough and chest congestion and green mucus for 10 days. Let's look at the objective portion is co-reg, which means his coronary regular rate and rhythm is fine. He does have a left-sided wheeze, rhonchi in all the lung fields. HEENT, head, eyes, ears, nose, and throat. Pupils are equal and reactive to light. The TM is intact, and he does have nasal congestion. Now, when we look at the assessment, it says, and this is a beautiful diagnosis because it is clearly written. Often when a physician assigns COPD, they don't put with acute exacerbation, and so you know in the medical coding profession, you can only code from what is documented. So here we have a great, great diagnosis, COPD with an acute exacerbation. We, for the P portion of this, which is our plan, it says to discontinue tobacco. He is prescribing Levaquin 750 milligrams, one a day, number 10, which is an antibiotic. He is also prescribing an inhaler, an Advair inhaler, 250. They come in 3 different strengths. He is telling him to increase his fluids. He is ordering a chest x-ray. So all of this would enter into your medical decision making, along with all these boxes that are up here, this template that we use. He's saying he wants to recheck him in 3 days and to go to the emergency room if the condition worsens. And the last but not least, number 8, he is saying to refill the lisinopril for hypertension. So that means that we can pick up that hypertension or hypertensive vascular disease as an additional diagnosis. So I can tell you as a medical coder that, of course, our primary or first listed diagnosis is going to be our COPD with acute exacerbation. What you're looking at on this picture is an actual 1500 form. I'm just making up that we're submitting this claim to 21st Century Health and Benefits. You can see the demographics of our patient. I've changed, the city and town. It's, of course, our own internal ID number for the patient, patient's date of birth, whether they are the subscriber of the insurance or not. But down here, we get into the coding portion of our 1500 form with in the number 1 slot is our COPD with acute exacerbation. I am also picking up smoking because, again, that is just something that would obviously significantly impact somebody who is having COPD, or, again, like I had said, most places absolutely want you to pick up smoking if indeed that patient is a smoker. And the 401.9 is for the hypertensive vascular disease or hypertension. Now, these are ICD-9 codes, which obviously we are still using ICD-9 until 10/1/2014, which honestly is right around the corner. So we're going to say that this person was here on 10/2/2013, and we're going to assign a level 4 new patient office visit, which is 99204. Now, I'm letting you see what an actual 1500 form looks like, but again, almost all claims are submitted electronically, so there would really be no need for this form to be printed out, meaning that we are paperless. Now, I want to go into one more patient to show you another progress note before we go back into the office computer so that I can show you how we would code this particular visit in the computer using our software. So now we're looking at Elizabeth Smith, and she is an established patient, so we would use established patient E&M codes. I'm highlighting again things that I would like you to pay attention to. The SOAP, again, these docs use this format, which is really beautiful. Subjective portion of this, the patient is complaining of black stools for 3 days. Again, over in this right section is our template that we can use to assign the code. And honestly, a lot of physicians are very familiar with the level of E&M. And I will also tell you that with the introduction of the electronic record, that it is extremely easy to assign an E&M code because they're driven towards all of those different items that you must meet in order to come up with the level of service. In fact, there's even talk that they may even have to address the EMRs in the future because too many office visits are being billed at a higher level than really what they should be. But in the interim, I just want to show you, go back to this progress note. Okay, so black stools times 3 days associated with vomiting of black material. This patient is on Zocor. Zocor is, as you should have learned, a cholesterol drug. It's 20 milligrams, and he takes 1 HS, which means 1 at bedtime. He's also on, or she, I apologize, is also on Toprol XL 50 milligrams, 1 in the morning. That is a blood pressure medicine. And she is also on Vesicare 5 milligrams. Vesicare is used for overactive bladder. He is indicating that there is an allergy to sulfa. The objective portion, again, we have coronary is regular, approximately 78. Lungs are clear bilaterally, HEENT and Perla. Conjunctiva pale, and the TM is intact. Her abdomen, because remember she is having black stools with vomiting, is soft, no guarding, no rebound, tenderness. There's positive bowel sounds, and there's no edema in her legs. So he is assessing that there's an upper GI bleed. Okay, now remember, if you remember when we discussed medical coding, or even back in medical terminology, upper GI, there's a lot of different parts of our upper gastrointestinal tract. All he's saying is that it's upper GI, so that's kind of, it's what we would consider more unspecified. The plan is that the family is present, they should go to the emergency room now, and that the office staff is going to call the ER to give a report. So I can tell you with this particular patient, obviously our primary diagnosis is the upper GI bleed. I would also pick up vomiting, and that's why I have it in yellow here. And the reason for that is because just because you have an upper GI bleed does not necessarily mean that the patient is vomiting. So let's go down and look at our form. Again, in the very top half of a 1500 form are the demographics of the patient. I am saying that she is the subscriber. I am billing this as a level 3 99213. Our first listed diagnosis code is the GI bleed, with the second listed code as the vomiting. Okay, now let's go back into the computer and let's go into the charge tab. I realize this is a little fuzzy for you, but you're still going to get the general idea of what we're doing. So let's start out with Joseph Brown. I'm going to type in Brown, and I can put in just a couple of letters, and I can see all of the Browns that we have in our computer. I'm going to pick the right one. He's already been entered. I'm going to use the date of service that we said that he was in, which I believe was 10:05, if I'm not mistaken. So let's just put that in here. So I'm going 10:05, and of course that is the end date because we're doing outpatient. Actually, it was 8:20. So let's fix that. I'm going to use 2013. I entered the provider. We have 2 doctors in our practice, so I just enter which one is the correct one. Now here, my cursor is blinking at the procedure portion of this encounter. So we have all of our own internal codes for what a 99213 is, 99214, 99212, or whether it's a new patient, then you would know that the second to last digit of a CPT code would be a 0, as in 99204, 203. So what I'm going to do here is I know that we said we were going to assign a 99204. So my internal code is 204, which translates to a 99204. And I'm going down to the charge detail, and I have enough spots for only 5. But remember, his diagnosis is COPD with acute exacerbation. Again, we have our own internal codes in here, and you can do that in almost every practice manager system. You're going to have the codes in your computer that your docs use most often. We're primary care, so we use a lot of everything, to be honest. But this eyeglass that I'm going to press on brings me up to a diagnosis lookup. I'm going to enter COPD just so that you could see some of the options that we have in here. So we have COPD with acute bronchitis, with acute exacerbation, with asthma, or with chronic bronchitis, or we just have plain old COPD. Again, we're looking at ICD-9 codes because that's where we are still with our coding system. Now, Mr. Brown was documented as COPD with acute exacerbation, so I'm going to choose that. It's going to land right here. Then we're going to also enter the codes for the hypertension, which I can, again, use my hourglass or eyeglass, type in the word hypertension, and here's all of my different hypertension choices. I'm going to choose the unspecified because that's what he said. Now remember, of course you would have a coding manual at your side and you would be using it if the codes that you were entering in the computer were not part of your, what we call, favorites. So I've been working at this practice for a very long time, so I know what to enter. I've created a very extensive list of our most frequently used diagnosis codes, but there's always going to be instances where you will have to rely on the book. And I'm just going to enter the code for smoking, which is 305.1. And you can see it comes up as nicotine addiction. Then all I'm doing is saving this. And then I can go to the next patient, who our next patient was Elizabeth Smith. So I'm going to type in Smith, Elizabeth. There she is. I'll just use the same date just to make it easier. Now we know that we were going to bill her as a 99213, which is, in all honesty, probably one of the most common office visit codes, a level 3. So in my practice management system, I have my internal code for a 99213 is simply OV, which stands for office visit. Now, we said that she had a GI bleed, unspecified upper GI bleed, which is 578.9. Because I've been doing medical coding for so long, I know a lot of codes by heart, which is really to your advantage as we get into the ICD-10 and the codes are going to be so much longer. It's going to be kind of impossible to remember them, and especially for somebody who is new breaking into the field. We're all starting out at the same place again. But now let's just say I don't remember what my vomiting code is. So I put in the word vomit in my search criteria. I have two entries. I have vomiting or whether they're vomiting blood. Well, we're just saying that they're vomiting. And then I'm going to save this. Now, after I've entered all of the information for all of the patients that say our physician saw on a given shift, I would then go into my insurance billing tab. I would choose whether these claims are going to Medicare or whether they're going to what we use are clearinghouses. If it's not a Medicare patient, I'm not going to do it, but I would just simply click on one of these items here and then click down here on batch run. I would click the start now button, and in less than 10 seconds, I would be ready to send electronically my batch of claims. And if there were any explanation of benefits that needed to be retrieved from Medicare, they would send those electronically, and all of my Medicare EOB is automatically handled with the computer. They are electronically reconciled and they are electronically posted to that particular patient. Not every insurance company has that. The only one who works like that is really Medicare. So again, I'm going to just cancel out of here, and I just wanted to show you again, if we were doing appointment scheduling with an appointment book, we have here a documents tab where we can print a face sheet, a charge slip, receipts, statements, itemized charges, itemized payments. I can put my own notes in the patient screen. If I went back into, say, let's go back into Miss Elizabeth Smith and say I wanted to enter something about I needed to get in contact with her daughter because this woman is 88, I could put in a special note in here, and I can enter my own note, and then it would pop up every time I went into her screen. I could also go and have family links on her, or I could go into her patient statement if I wanted to print out a bill for her. So again, the only reason I'm really showing you this is just to give you an inside peek at what it would be like if you worked in a physician office. If you worked for a hospital, you would not be, if you were a medical coder in a hospital, you would be only doing the medical coding. The billing department of the hospital would be following that claim through with the electronic filing of that claim. That's another reason why I personally like working in the outpatient environment, because I get to see the whole picture. It's a big giant circle from when the patient comes in. I get to see their chart. I get to code their chart. I get to file their claim to the insurance company. I then get to receive that explanation of benefits. I get to post the payments in the payment. Let's just say we wanted to post a payment for Elizabeth Smith. These are all the visits that she's been here. I just pick the one that I'm posting for, and then I would post the payment. And if there would be a balance that was due from the patient, then when the statements are printed out, then that statement would be printed out for that patient and sent out. So again, I encourage you to look for a job the same way that you would study for any class in the program. Finding a job is a job in itself. Don't give up. Be very diligent and apply for everything. And again, don't be discouraged with inpatient versus outpatient. If you have any questions, you're more than welcome to get in touch with me via email through the college. And this concludes the part 2 of this presentation. Thank you.